I had to give the mother two pieces of bad news. I had to give the mom bad news that her son has something going on in his brain, and that was likely causing his heart to stop. Welcome, everyone, to a new show here on HuMed, Human Medicine. My name is Dr. David Spiro, and welcome to our podcast today. Today we're doing something a little bit different. We're turning the tables, and I'm the one that has the story. And I'd like to introduce my unbelievable, fantastic, amazing, outstanding podcast editor extraordinaire, Ty King. Ty, welcome to the show.
Thanks, David. That is a lot of descriptive words you used there, and I appreciate it.
Well, honestly, there's a lot of work going into making a podcast. There's obviously the parts of getting guests and all that, but there's also what happens in the background, and you're an incredibly talented podcaster, and I really am honored to have you as part of our team.
Yeah, I appreciate that. There is a lot of work that goes into this on both sides, and this is a fairly new show, but it has really taken off, and I think it's really about the stories that are being told here.
Yeah, so just so everyone again knows a bit about me, I'm a professor of pediatric emergency medicine at the University of Arkansas Medical Sciences, and I work at Arkansas Children's Hospital. And I've had a unusual career to date getting to here, and oftentimes I ask the guests how we got here. Well, I grew up in New York. I went to college at the University of Virginia and medical school in San Francisco. I did my residency in Denver. And then right after my residency, I did not know exactly what I wanted to do, and I wanted to sort of have a period of time and practice and hone my skills as a pediatrician. So I ended up in a rural town on the coast of Oregon. And this is as a pediatrician, not as a pediatric ER physician. And I work with an incredible mentor, Dr. Stephen Burns, and he really taught me how to become a physician, and I really learned how to become a doctor, challenging myself in a rural environment. We were 3 to 4 hours away from the closest children's hospital, which was Oregon Health and Science University. And the story I'm about to tell you today is one of the most impactful stories that affected me as a young physician, and really allowed me to think about how I interact with families during crisis situations, and made me very mindful moving forward of how to do that. So let me get into the story, which is always the grounding force of this podcast. So I was probably 2 years into my 5-year stint as a rural health pediatrician, paying off my debt, kind of doing my thing. I had established a number, probably 1,000 to 2,000 patients at this time as part of my practice, and I also worked on a Native American reservation. And 95% of what I did, I worked in a mobile trailer, which was my office, if you could believe it, that was adjacent to the hospital. And I would see patients there, and 30 to 40 patients a day, and child visits, sick visits, immunizations, all the different things that a general pediatrician does. But a couple times a month, I would be called at various hours, oftentimes during the day, to the hospital ER when a very, very sick child would show up to the emergency department, because at that point in the early 1990s, they didn't even have board-certified emergency medicine physicians that manned the ER. They had family doctors or internal medicine doctors, and depending on who was on, they may or may not have they may or may not have comfort taking care of children with very severe emergencies. So I was working in the office one day, all the crazy things going on, running from room to room and taking care of families. And I got a call out of a room saying that one of the family doctors was on the phone and wanted to speak to me urgently, not from the ER, but from his office. And his name was Dr. T. I will keep initials here just for anonymity. So Dr. T called me from his office in Walport. I was in Newport, and Walport was 20 minutes south, another small community as part of Lincoln County, which is where I worked. And he said, David, I've got a kid here that's not doing well in my office. And I said, tell me more. What are his vital signs? And he said, I don't know, but he's not moving well. And so I said, well, why don't you go in and see if you can awaken him and try to figure out what his pulse was. And do you have a pulse oximeter? Yes, I do. And tell me what his heart rate is and all the rest of his vital signs. So the phone gets put down. I'm waiting uncomfortably on the phone. And he comes back and says, I can shake him. He's moaning. And his heart rate is about 40 to 50. And he's not breathing very well. So I said, okay, why don't you call 911 and have an ambulance bring him to the Newport Emergency Department, and I'll meet you there. So I have my partner, and we had a physician assistant working with us at the time to take over my patients in the clinic, and I walk over to the emergency department, anxiously awaiting this child. About 20 minutes later, they bring a child in who is completely unconscious and indeed has a heart rate of 40. His oxygen level was very low. It was in the 70s, and he wasn't breathing fast at all. His respiratory rate was probably 4 or 5 per minute. And normally a child this age, and he was, by the way, 7 years old. And again, not primarily a patient of our clinic, someone else's clinic, but I would get called for any child less than the age of 18 with any serious emergency. So I was sitting there figuring out what to do, and it was very clear that I needed to put a tube in his throat, or what we call intubation, to stabilize his airway and get him to a CT scanner. So we did all the different things that we do as a team. We put in an IV, we got some blood work, and gave him some medicine to go to sleep, and I put a tube in his throat. Got a chest x-ray to confirm the tube was in the right place, and immediately his vital signs improved. His heart rate came up. His respiratory rate came up, and we took him to the CT scanner. Meanwhile, the mother came in, and I said to the mother, I said, what's been going on? She said, well, he had a normal night the night before, and he woke up with a headache. And then I gave him some medicine, put him on the couch, and then I came back 30 minutes later, and I couldn't wake him up. So I took him to Dr. T's office. So I said, okay, does he have any major medical problems? And she said the only problem he has is attention deficit hyperactivity disorder. He takes Ritalin for that. He's had some cold symptoms recently, but really nothing much else. So then I hurried back to the CT scan room and spoke to one of my colleagues, who at the time I believe was Dr. James Schmickall, one of the most intelligent radiologists I've ever worked with, general radiologist, but just so smart. And when you're working in a rural town, you get to find out early who the people you can really rely upon. So we look at the first images of Matthew's brain, and it doesn't look good. It looks like he has a mass of some sort in his brain that's either a tumor or or blood, or what we call an arterial venous malformation, or an AVM, which is like a blood tumor that may have ruptured. But either way, it was not a good CT scan, and we brought him back to the main ER, and I immediately called for a helicopter. While I was calling for a helicopter, Matthew's heart rate started to drop, and he started developing what we call Cushing's triad, which is high blood pressure and low heart rate, and he ended up having a cardiac arrest, which means his heart stopped. And so at that point, we were doing CPR to try to revive him, or else he was going to die. And so we started giving him CPR meds and a medicine called mannitol at the time, because we didn't have hypertonic saline then. This was 1997, no, probably 1996. So we gave him a medicine to reduce his pressure in the brain, and we got his heart rate back. After about 10 or 15 minutes of CPR, the social worker came in to the ER and said, "David, the family is outside in the waiting area. Will you please come out and talk to them?" And I said, "Okay, this is a good time to talk to the mother again." So I walked out into the courtyard. It was a beautiful sunny day. Remember this, like, it's crystallized in my mind, Ty. I walked out into this courtyard, and the mother is sitting on a chair. And at that point, there were 20 or 30 family members there, friends, family members, and I had to give the mother two pieces of bad news. I had to give the mom bad news that her son has something going on in his brain, and that was likely causing his heart to stop, and he needed to be transported to Portland by helicopter. And of course, this was a child and a mother that I didn't know before this happened. And this was a child that, and I didn't know the child, I didn't know the mother. It's very similar to situations that I have in the pediatric ER now. It's very rare that I know the families before I have to give bad news. So I walked up to her in the courtyard. I kind of bent down and I said, "Can we go to a quiet room, and can I talk to you privately?" And she said, "Whatever you have to share, I want everyone else to hear. So you can tell me now." So I pulled up a chair, and I said to this person's mother, the patient's mom, "Well, your son has blood in his brain, and I'm not sure why. I don't know if it's a tumor, or if it's a blood tumor, or what we call an AVM, but the bleeding is pushing his brain down and causing his heart rate to stop. And so we had to do CPR for a little bit, and he's very sick. And I've given him medicine to put him to sleep, to keep him out of pain and discomfort, but I called for a helicopter, and we are sending him to Portland, Oregon, to a pediatric ICU, and to meet with a neurosurgeon." So she kind of thought about it all and didn't really say much. She was crying. And I said, do you have any questions, or does anyone have any questions? And so she said to me, "Is he going to survive the transport from Newport to Portland?" It's about a 45-minute helicopter ride. And I said, "I don't know." I said, I want to pray that that happens, but he is so sick, I can't tell you if he will survive the trip. And somewhere along the way, she had shared with me this is her only child. And so she looked at me with eyes that I'll never forget, looking at me, piercing through my soul, and said to me, "I hate you." And so I sat there for a little bit, and I said, "I'm sorry you feel that way. I'm going to do everything I can to take the best care of your child." And I got up and went on my way back to the emergency department. And he didn't have another cardiac arrest, thank God, and got him into the helicopter. I usually walked the children to the helicopter with the flight crew from, I believe, Oregon Health and Science University, and we sent him on his way. And I think one of the things that I took away from, and there's a second part to this story, which we may or may not get to, trying to keep these episodes to 25 or 30 minutes, because I could go on and on about this story. But I think what I have learned over the course of my career is that everyone has their own reaction to bad news, and you just have to respect what folks' reactions are. And my job is to be very brief and honest and authentic in that moment. And that's it. And compassionate. And answer questions as best as I can, if I can. And just sit with that, knowing that that whatever I say is going to be imperfect and challenging. So I learned a lot from that. I really, really did. And what was interesting about this particular case is I had not heard much about this patient for a few months, and I assumed he had passed away, because he wasn't my primary patient. And so I was in my office again, and I got a call from the ICU asking to speak to me. So I spoke to the physician there, and the mother apparently had made a promise with God that if he survived this trip, he was going to keep her alive and bring him home. The hospital, he became brain dead. His body was alive, but his brain was dead because of the insult. And it turned out that it was an AVM, an arteriovenous malformation, that had ruptured. And anyone can have it unless you scan your brain. You don't know. Very rare. You can have AVMs anywhere in the body, but if it's in the brain, it's a bummer. The other, I think, lay word is potentially aneurysm. But I got a call from the ICU physician 3 months later who asked me, the mom is requesting if you would, they're transporting the patient back. He has a tube in his throat, still in his throat, which is now a trach. He had a procedure to put, what Dr. Nolder did in a previous episode, to put a hole in his throat to breathe for him, and then he had a tube in his stomach to feed him. And mom was planning to bring him home, and she lived up the Alsea River, far from 25 minutes from Walport. So this was a good 45 minutes from my office. And the ICU physician said, would you take the case? Because the family doctor didn't feel comfortable taking care of him. And that was another interesting dilemma. It's like, do I care for a child that's in a persistent vegetative state in a rural area that's not my patient, but I took care of him, and the ethics about that and around that, and decided I would. And so spent the next 3 years until I left Newport taking care of this patient and visiting every week and doing home visits and doing all the crazy things you need to do to keep a child alive in a persistent vegetative state in a trailer home that the family lived in. I got to know the family very well, and
Yeah, so I mean, obviously this story was very impactful. It's where you can clearly see it in your mind. And usually, and like you said, I cover recovery on several different subjects, but it's kind of different because usually it's not clinical, right? It's usually people that have been through those experiences that are helping other people through those same experiences. But for you, just curious, because I know, I think I'm the first one on here that's not medical staff or a doctor.
but you're a human being.
Right, right. I've heard plenty of impactful stories that have been told here. And even though, you can tell there's a lot of emotion behind it, right? They still kind of deliver the story in a way where it's kind of like what you did with the mom, where you had to step out there and in front of the family and tell them, hey, here's what's going on. Here's honestly what's the truth. I did my best. And, for them, before you went into the operation room, they were putting all their hope into you. And then when you come out and have to tell them something like that, then you become the object of, where they can project all of their, despair and pain and everything that they're feeling in the moment. How do you deal with that as a doctor whenever you're putting yourself in that position?
Well, at the time I was really junior, and I took it really personally. At first I thought, what did I do to screw this up? What did I do to not give the mom the right information or say it wrong and whatnot? And use the word that is correct, which is projection. The mother was projecting a lot of her emotions on me. And one of my mentors, Mo Daya from Oregon Health and Science University, one of his mantras was, try not to take too much personally. And we tend to take a lot of things personally, both in a relationship and as the relationship of a physician and a patient and a family. And most of the time it's not personal. Most of the time it's the situation that is really difficult, and it's how we manage it and deal with it, and there's a little bit you take away personally, because there's no perfect and there's no right answer to any of this. So there's always an opportunity to learn and grow from any of these situations.
And obviously this stuck with you, and you've thought about this, I mean, for a lot of time. You're still a doctor, though. You stayed with it.
That was like 30 years ago, my
Right,
friend.
right.
Holy moly.
So 30 years later, we're still talking about this story because it made such an impact on you. How did you take that experience? And I'm sure that wasn't the only time that you've ever experienced where you're having to deliver some bad news or something that somebody doesn't want to hear, and they project that on you. How have you taken all those experiences into the way that you implement and the way that you do that now in a healthy way?
Well, now what it is I get to teach it. So if I'm with a learner, not a junior learner, but someone who's maybe a fellow who's studying pediatric emergency medicine, I will prep them and sit with that learner while they give bad news, if it's appropriate, and give them feedback. And that is an opportunity to take what happened with this family 30 years ago and use and harness some of the learnings from how to give bad news and how to deal with bad news to to our new learners. I think about our conversation with Dr. Yu, which we should have him back on the show again, with artificial intelligence and the idea that some futurists think that we'll be having robot doctors and robot podcast editors and all sorts of things. But I just, it's beyond comprehension to me right now how a robot could give bad news like that. And maybe there'll be some synergy between AI and human beings. There are some folks who think that human beings won't exist as they do in 100 years, and will be some sort of synergistic human AI something. But I think, and ultimately, this is part of the art of medicine, and it's part of the very complexity of what we do in the right moment. Because what happened in that particular case, and oftentimes in my world where kids come in dead and stay dead, because most of the time when a child comes in with cardiac arrest, like 98 times out of 100, if they come in cardiac arrest, we cannot resuscitate them, and they end up dying. And the acts that we do in the emergency department, CPR, epinephrine, putting tubes in various places, none of that is relevant at the end of the day. And at the end of the day, the most important act and thing that I do in those situations is deliver bad news. Nothing else is important, because nothing else made a difference. But how you give bad news can make a difference in that situation.
For sure. And I would think that that's not, doesn't always happen, doesn't coincide with the end of your shift either, right? So like you've got to move on from that moment to where if they do project like that onto you, then you've got to go into the next room and deal with the next patient. So how do you, as a doctor, as a physician, how do you, I don't know, like take care of your mental health so that you can still provide the services? Because you're a very well-mannered, person, like who David is on the outside of the hospital is who I imagine that you are on the inside. Like I've never seen you like raise your voice, or you don't talk outrageously or anything. Like you are very, in control of yourself.
But that's not true. I actually play Bee Gees really loud at the house and have, because I'm all about the 70s. No, I am pretty calm. I think that it is intense, and oftentimes letting go and closing the door and having a cry out, or taking some deep breaths, or walking outside for a few minutes and taking that break. The other thing that we do oftentimes after resuscitations, is we do a debriefing with the team, where it's an opportunity to express what went well, what didn't procedurally, but it's also, more importantly, an opportunity for the team to sort of talk about how they're feeling. So those debriefs, if it's done well, there's an opportunity to emotionally express yourself.
How was it different for you? Like, how did it feel for you to be able to go back after the boy, came back, and that you were still able to go and still take care of him even in the vegetative state? Because the most of the time when you're delivering this bad news, it's not because you're going to be able to go back and help that patient. They may be gone, or you may just never see them again because they go through a different system in the hospitals. But how does it feel differently whenever you're able to go back and to treat them? Did you have an attachment, or did you feel a responsibility to continue the job, or was it the way that the family, I don't know, attached to you?
Yeah. So when I came back to the family's residence for the first time, I didn't know what to expect, because, like you said, the last thing I remember was the mother saying, "I hate you." That was her last words to me. So I walk in and I was greeted like a hero. Hugs, thank you so much for what you did to save my child's life. And it was shocking to me. And I was warmly greeted, respected, and treated very well by this this family. The years later, after I got to know the family, because scores and scores of visits, right? So you get to know people in their house, sitting in their living room, and I related the story back to the mother. I said, "Listen, do you remember what happened?" And she said she didn't fully remember it. She vaguely remembered me giving her the news, and it was in the courtyard. And I said, "Do you remember what you told me?" And she said, "No." And I said, You had said to me, "I hate you." She said, I didn't say that. So, and she did say it, for the record. But isn't that interesting? And it turns out there's a lot of literature on this subject, some research. And 90% of what doctors tell patients during a traumatic situation like this is completely forgotten. And it's probably because there's certain parts of the brain, like the limbic system, that take over the fight or flight response. And that's not where your body's energy is. You're not supposed to do deep cognition processing when you're in fight or flight. You're supposed to be getting up and running, and your adrenaline is pumping, and you just don't remember much because it doesn't serve you well. And it is a protective mechanism as well, right? From a psychologic standpoint. So, as we're nearing the end of this episode, I can tell you what had happened at the end, because part of my time with the family was, I'm not here to convince anyone, but talking with them about really what is the end game here, because this is a really difficult situation. And the mother was pretty convinced that he was going to make a recovery. And at that point, I had made a decision to leave the community. I'd found a physician and his wife to come and replace me, who, by the way, are still there 30 years later. It's pretty incredible. So that was maybe one of the most important things I did as a doctor there, is I found replacements, plural, that are still working. And I distinctly remember taking my new colleague out to this house and saying, "Listen, I've got a complex case I need you to manage after I leave," and introduced him to the mother. The mother was she seemed unhappy I was leaving. When I told her I was leaving the community, she seemed unhappy. And about a month after I left the community, she brought her son up to Portland, back to the ICU, and they ended support. So there's so many things to talk about there, and again, I don't want to extend the episode more than our brief period, but was I part of the problem? And you could argue that maybe I was, and you could also argue that maybe it was unethical for me to take the case, and I still sort of go back and forth. But I certainly learned a lot as a physician from taking care of this child at the beginning and towards the end, and everything in between. Also really makes me appreciate physicians that work in the community and in the rural setting, and the different challenges that they have and barriers to good care when you're working in a small town.
Difficult. I've talked to several people that run, small, practices that are emergency, centers, because rural, when you live out in, especially here in the South, like there's so much country where you just have to drive 20, 30, 40 miles to even get to the emergency room without those smaller emergency rooms that are around your area. And are they going to make it in time? And so it's really difficult. So I'm sure the stress and everything relays over to the doctor's side as well.
Well, Ty, thank you for asking me great questions. Thanks for suggesting that we turn the tables around here. It was I feel very therapeutic actually just talking about the story. It brings back a lot of memories and really allows me to think about how these stories have really impacted me as a physician and the way I practice medicine. I want to thank you, Ty, for being an outstanding host and all the different things that you do in the recovery community. And I want to thank our listeners for listening today. Please join us on YouTube, Spotify, Apple Podcasts, wherever you listen and hear these kind of things. And thank you for joining HuMed, Human Medicine, a way for us to speak from the heart and learn from stories from my fellow colleagues. So have a great day.
Thanks for listening to HuMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.